Great. Good morning, everyone. Welcome to our Cardio Echo QI series on cardiovascular disease. We're excited to have you all here this morning. As you know, this is a partnership with all the medical schools across the state and the Ohio Department of Medicaid and MedTap and the GRC. So just a little bit about who we are. We were founded in 2017. As I mentioned, it's a healthcare professionals across the 7 medical schools. We identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. We do it through a variety of mechanisms: online resources, newsletters, podcasts, webinars, and quality improvement using the Project Echo virtual training model. Next slide. So just so you know, today we're going to do introductions. I will give a didactic presentation, then I will turn it over to Gautam, who will do the clinical pearl and the case studies. And then Amanda will facilitate the report outs where I think people are going to share their GEM talks. And then Andy will wrap us up and talk about next steps. So these are the 6 sites that are participating across the state. You can see they're mostly Northeast Ohio, but not entirely. So welcome, everybody. This is our project team. We're led by Dr. Constant and Dr. Bolin. I don't think Dr. Bolin is with us today because of the Jewish holiday. And Gautam and I co-lead this. Amanda's our QI coach. And then we have our project management staff, which is Claire and Andy. And I just want to take a minute to recognize Dr. Austin, who's joining us for the first time as one of our coaches. He is taking over for Dr. Holliday, who left University of Cincinnati. So I don't know, Dr. Austin, if you want to unmute and introduce yourself.
Yeah, so I'm Austin Austin, and I've been with the University of Cincinnati for a long time. In fact, Professor
Oh,
emeritus, but enjoy. So thanks for having me.
welcome. Next slide. We don't have any
Thanks.
if you want to receive CME credit, you'll get an email with the for next steps. Once you opt in, you'll automatically be opted in. If you don't get the email, please reach out to Kathy Sullivan or anybody on this team, and we can get you in touch with Kathy to make sure you get your CME. And then we're also happy to help with maintenance of certifications in family medicine. And please do not share PHI. So today for our brief didactic, and full disclosure, I'm recovering from a horrible cold and I'm losing my voice. And so I apologize for that, for sounding like a dying seal, but I will do my best to get through this and not hack up a lung. So today we're going to talk about key driver diagrams, fishbone diagrams, and Pareto charts. We're going to talk about how we can apply these to causes, prioritize interventions, and map strategies for achieving measurable improvement, and then really integrating these tools into ongoing clinical workflows to drive sustained team-based change. I'm Aleece Caron. I think you all know who I am. Next slide. Okay, so the first thing we're going to talk about are key driver diagrams. So what happens with the key driver diagram is teams get together and you've probably been working on this with Amanda, and you theorize about what changes will result in improvement. It really helps you, the key driver diagram will really help become your roadmap for change, and it helps to define what should be measured to best learn how your interventions are impacting your system. So there's a basic anatomy, there's an aim, and I'm going to show you a picture in a minute, which you've worked on already, which is your clearly articulated goal or the desired outcome. So good aim to answer the question, how much improvement to what, for whom, and by when? And then you have your key drivers, which are high-level implements or factors to change within the aim. The secondary drivers are components of the primary drivers and often include specific change ideas to test for each key secondary driver. You have a date, which documents the key driver diagram version date. So keep in mind, these are living documents. So your key driver diagram and your aim and your goal may change. You may start to focus on different drivers within your key driver diagram. And just keep in mind, there are many variations of a key driver diagram. The correct anatomy is the one that meets your team's needs. I'm just going to show you one example, but if you go to the literature, there are many, many examples. So this is basically the outline of a key driver diagram. So as I mentioned, you have your aim, or your outcome. You have your primary driver, which are the smaller, the column with the 3 boxes. Then you have your, I'm not sure what happened to the label, but there's secondary drivers, which are the the 9 boxes. And then you have change ideas, which contribute to the secondary drivers, feed into the primary drivers, and hopefully help you achieve your aim or your outcome. Next slide. So this is an example for another project that we're working on through Cardio. It's our QI Hub project for Northeast Ohio. So our global aim is to reduce complications associated with uncontrolled type 2 diabetes while addressing health equity. Smart aim for this particular project is to reduce the percentage of adult patients enrolled in Medicaid with type 2 diabetes whose hemoglobin A1C is uncontrolled, which is defined by greater than 9. And we were still in the process of defining what this was going to be. We have since updated it, but so you can see you put in, you want to reduce it by how much percent or from X percent to X percent within a certain date. And then we also had another smart aim within this, which was we really wanted to address the equity issue. We really wanted to focus on percentage of uncontrolled patients in the Hispanic and non-Hispanic Black populations as well. Our overall population is adults 18 or older in the Medicaid patient who have Medicaid and have type 2 diabetes at our participating practices. And then we have our key drivers. So we were focusing on appropriate and timely treatment, access to high quality coordinated care, screening and well-managed behavioral health, patient engagement, healthy lifestyle and self-efficacy, effective supportive relationships, and healthy, equitable environment of care. So you can see that the boxes in orange are clinical drivers, and the blue drivers are more social support, team-based care, things that we need to focus on so that teams function properly to be able to address the clinical drivers. And then the interventions are, I'm not going to read through all of them, but you can see that, we've mapped the interventions to the key drivers. So by way of example, optimizing medication regimen across conditions maps to drivers A, which is appropriate and timely treatment, access to high quality coordinated care, effective and supportive relationships, and healthy, equitable environment for care. Are there any questions about this? Okay, next slide, please. So
this is Arpita. Sorry, I have a quick question on the key drivers. Do we have to have the key drivers ready before we make a smart aim and the global aim?
So that's a loaded question, and I'll invite Gautam and Amanda to weigh in. Sometimes you have your key drivers identified, but oftentimes this is like I said, this is a living, breathing tool. And so you may have identified your smart aim and have hypothesized what your key drivers are, but they may not, but what you're actually working on may come to light as you're going through your planning process, and you may identify additional key drivers, or the ones that you have identified initially may not be the appropriate ones.
Thank you.
Amanda, Gautam, I don't know if you want to add
Yeah, Aleece, thank you for that. And thanks, Arpita, for the question. So here's an example. So I'm the PI of a study called Empower, which deals with screening for urinary incontinence in primary care. And we think about why is it underdiagnosed, and the key drivers are women don't want to disclose it, physicians don't have time to address it as well. One of the drivers that emerged after we had constructed a key driver diagram was that the receptionists weren't aware at the front desk of the study, and there was a lot of turnover, so they weren't handing out the questionnaires. So we had low screening rates across the board. So that's something that would emerge after you've started implementing, which is what Aleece is getting at as well.
And
Thank
the
you.
other thing to keep in mind too, Arpita, is by way using Gautam's example, that you can't just focus on clinical drivers. You have to really look at how teams function and making sure that everybody's involved in the process who touches the process so that they're able to contribute appropriately.
Okay, thank you.
Amanda, I don't know if you wanted to add anything.
The only thing I would add is a lot of times when we're in the planning phase of a QI project and building these key drivers, I often, after you create your process map, we'll take that process map and put it like on like a failure modes effect analysis, and then you can actually take those identified possible failures or interventions and kind of play into that and tie that into your key driver diagram as like interventions. And then I also think about like the key driver is the what are you going to do, and then the interventions is how are you going to do that. So that's how I sort of separate the two.
That's a great point, Amanda. Thank you. All right. Any other questions? Okay. So keep in mind, this is a team activity. While I know some of you are here individually and you haven't been able to bring your team members, this is something you should take back to your team, and Amanda will help with this if she hasn't already. You've already decided on your project aim, but that's the first thing you would do. You want to brainstorm all system elements or factors needed to achieve the aim. And then you want to group the elements and define headings for each grouping. Generally, these are the primary drivers. They're not always. There's no right or wrong way to do this. So, Amanda will help you think through what your primary and your secondary drivers are. You want to check for any missing factors or drivers. And then you validate this through observation, which you might have done when you did your Gemba walk already, data, and reviewing individuals performing the work. And then you want to brainstorm interventions you want to test for each driver. And these are each primary driver, and these are your secondary drivers. Then you'll populate your key driver diagram. You want consensus for your theory of change. And just keep in mind, one intervention can impact more than one driver. So secondary drivers may have more than one arrow. As you could see, by way of example, we mapped a bunch of our secondary drivers to the primary drivers in the previous diagram. And then you want to decide which drivers you believe are important to measure, and if you will measure for the duration of the project or just for a limited time period. All right. Any questions or comments on key driver diagrams before we move on? And if you want to share experience in using any of these tools, please feel free to unmute or raise your hand or pop it in the chat. I think Andy's monitoring the chat. So the next tool we're going to talk about are fishbone diagrams, also called cause and effect diagrams. And this is really a brainstorming tool. Your team is going to theorize about what's causing an effect. It really serves as a basis to begin your PDSA cycles or improvement plans. And then the causes that lead to the given situation are called the effect. Next slide. And as you can see, this is why we call it a fishbone diagram. Did somebody unmute to say something? Okay. This is a really old example. So you can see your major causes are the big blue boxes. So you have resources, culture, and education. And this is focusing on asthma. Why do language barriers impact asthma? So under resources, you can see that language barriers can often lead to a wrong diagnosis, lack of appropriate language services, lack of funding. There's a bunch of things under culture, like limited cultural awareness, distrust in the medical system. I think we're all painfully aware of that right about now. Different cultures, understanding, especially with mental health. And then under education, you have the patient's difficulty understanding written and verbal directions. So the big bones are the major causes, and that are the major themes of the causes. And then each little bone represents individual things that your team has brainstormed that might contribute to the actual the cause of why language barriers impact asthma. Any questions about this? Has anybody used a fishbone diagram that they want to share their experience?
I did use the fishbone diagram when we did a QI in residency for increasing the screening rates in patients with STDs for GC chlamydia. As part of, we found a lot of after the main things, we increase arrows to keep improving the project.
Yep, that's a great use of a fishbone, Arpita. Thanks for sharing. And like I said, this is a brainstorming tool. So, this is just, one more tool in our QI toolbox that can help you design your quality improvement project and help you really focus and kind of look at this around what you might want to focus your intervention around. All right. Finally, Pareto charts. Pareto charts are a graphical display of the most important factors contributing to a problem. It's a bar chart arranged in order from the largest to the smallest contribution to the problem. The principle is that 80% of the effects come from 20% of the causes. It informs your improvement efforts. So you focus on tackling the vital few, because and this is really important because we're all time and resource constrained. So we really want to focus on what's really contributing to our problem. And then for those history buffs, it was developed by Vilfredo Pareto from socioeconomic research. 80% of the wealth is owned by 20% of the population. And there's a nice little picture of him down at the bottom of the screen. Next slide. So this is what a Pareto chart looks like. So you have your X and Y axis, and you have your first bar representing the most frequently occurring reason for the cause. And then you have your frequency of occurrence. And then the line indicates the cumulative percentage. So how much, so you can see that about 80% of this is caused by the first bar, and then, just shy of 20%, and then it drops from there to create your cumulative percentage. Next slide. So here's an example of, we have software for you to do this. We have I think it's an Excel macro that we can share with you to create your Pareto charts. So this is an example of causes for medical no-shows. So this is just an example. So causes for medical no-shows, the number one reason for this particular team was forgetfulness, which contributed to about 38%. Time was second, cost was third, fear was fourth, and transportation was fifth, culminating in 100% of the causes for medical no-shows. And like I said, we have a tool for you. Maybe next month, I don't know. I don't think we've talked about this. Presenting Pareto charts as part of your report out. They're really easy to do, and like I said, Amanda can help with that as well if this is something is another tool you're interested in using. But once again, this is really important because it shows in this example that if patients are forgetting to come to their appointments, then what can we do to intervene to improve that? We can, and there's lots of solutions. I think a lot of people are doing things around outreach, so I don't need to go into that, but this just really helps you focus on, how to tailor your quality improvement project. Next slide. So what you want to do after you've identified which tool you want to use, and you don't necessarily need to use all of these. These are just some examples of tools that may apply to your QI project. And once again, Amanda will help you decide which ones to use. You want to start with your SMART aim that addresses your meaningful problem. And then you can use your fishbone and Pareto charts to focus your testing on the most important drivers. And then importantly, you want to build and update your key driver diagram as you learn. I think that goes back to Arpita's question. Sometimes things are going to change, and these are living, breathing documents. And QI is iterative and not one and done. And then you embed measurements into your workflow so that progress is visible and momentum is sustained. I think that's it. Are there any questions or comments? I'm just happy I managed.
Are you allowed to share those?
Yeah, we make the slides
sorry.
available, Dr. Austin. Yes. So.
And then when
Thank
we
you.
slides,
Thank you
I think
so
it
much.
might be helpful just to attach that Pareto template, Aleece. If we could do that for the practices, that would be great. Yes. And then we can maybe visit that on our next calls.
Yeah, I mean, it's really easy to populate, and then Excel will just actually create the figure for you.
Yes, I think this is a good time in the project to actually incorporate those Paretos.
And then
And
we will make sure to send that out too.
thank you.
Any questions, comments, concerns? All right, I think I'm turning it over to Gotham.
All right, thank you, Aleece, and thanks for all those great insights. I think you'll find that these are really simple tools that'll help you organize your QI effort. Even though if they don't seem obvious now, you'll be surprised at how many things emerge after you apply some of these tools. So I have a few minutes to talk about our clinical pearl. I'm going to talk about it from the standpoint of a clinical case. So Gloria is a 73-year-old woman who has type 2 diabetes, hypertension, obesity, and an LDL cholesterol of 160 milligrams per deciliter. She is on high-dose statin, 80 milligrams of atorvastatin daily or nightly. She doesn't have any myalgias or other symptoms. She's pretty adherent. She's a non-smoker. Let me throw that question out to you. What would people do next in this situation?
Yes, this is Bhaskar.
Mhm.
First of all, you want to make sure that she is adhering to some dietary rules. And of course, you can add something to the atorvastatin, like citinib.
Okay. Um, Great insights. And I will tell you, she's not adhering to any dietary rules, if that's helpful to consider. You mentioned ezetimibe. Any other thoughts before we get to a discussion?
Is she adhering to atorvastatin?
Yes, she is. Yeah. To the best, I mean, great question. I mean, to the best that we know, she is. I mean, she's doing her best, and I think that we can assume that she is. Okay. Any other thoughts? Okay. Let me give you some insights here. So she has uncontrolled LDL cholesterol. She's at quite high risk for a cardiovascular event simply because she has type 2 diabetes as well. She's a non-smoker, doesn't have any established coronary heart disease at the moment. Sorry, was there a question? Maybe just somebody clearing their throat. One of the questions that comes up is what is the intensification of treatment that might take place? And I think Vosker hit it on the nail on the head. She's not implementing any lifestyle changes. So obviously, physical activity, dietary changes to promote weight loss in particular would be helpful. Ezetimibe is the recommended step. Who would consider a PCSK9 inhibitor in her, like Repatha or whatever? Any thoughts about that?
So, Dr. Rao, it's Jim, Dr. Rao from East Liverpool.
Yeah, hi, Jim.
So, yeah, PCSK9 at this point in time, I may not, because that's kind of on the far end of the spectrum. Maybe ezetimibe. And then another thing that I would like to, regarding this case, because she's 73 years old, is if there is a question or an issue about compliance, so who is staying with her in the house or in the family? Is there a family member? Is there a nurse that visits? Because that helps a lot with compliance for that matter.
Yeah, and those are great thoughts. I mean, I'm going to assume, let's assume this is a well-educated lady living alone,
Hmm.
widowed, has children, grandchildren, and is doing pretty well in terms of adherence with the
Okay.
medications.
Okay.
She has medications for diabetes, for hypertension,
Hmm.
and for lipids. Um, Everybody is pretty consistent, and I'm very pleased to hear that. What I think we need to avoid is heading down the road of considering PCSK9 inhibitor in here. First of all, if she has, I mean, most of our patients are Medicaid recipients, and I'm not going to click on these links, but you can click on them later on. Basically, CareSource will only cover a PCSK9 inhibitor under two circumstances. She has established coronary heart disease and still has persistent LDL cholesterol, which she does, but she doesn't have established coronary heart disease. And the next thing is if they have familial hypercholesterolemia syndrome. So the way you determine the risk of that, there are many calculators. The Dutch familial hypercholesterolemia calculator is probably the best one, and that deals with things such as xanthomas, etc., but also a very early family history of heart disease, which this lady does not have, and persistent LDL despite treatment. So there's no way she qualifies for it. Let's say she's on Medicare, she's not going to be able to afford it. They will not pay for it. The right thing to do, as all of you have said, is to consider ezetimibe. Personally, I haven't found that it does any sort of great miracle on top of the 80 milligrams of atorvastatin, and Vosker and Orson and others, you may have a different experience with it. I haven't found it to be any kind of major change. What she really needs to do is to adopt lifestyle changes, not only for her lipids, of course, but for her obesity and her type 2 diabetes as well. Okay, any additional thoughts before we move on?
A quick question.
Yeah.
If we did you consider trying to switch to a different statin with high intensity, like
No.
Crestor or like anything alternate?
Yeah, that's an interesting point. I don't think, Arpita, we are at the point where we are in terms of personalized medicine. There is no question there is a differential response to different statins. And whether it's rosuvastatin, lovastatin, etc., or atorvastatin. The reason atorvastatin is so widely used is because of the large trials that were conducted that showed benefit. But there's no reason to think that simvastatin is any worse, for example. But you could play around with things. You may want to split her dose, maybe morning and night, see if you get a particular response with it. The age-old wisdom of taking your lipid lowering medicine at night, because that's when you generate the most cholesterol, has been proven not to be valid because these medications last for 24 hours. But you can consider splitting a dose. But that having been said, I don't think you would get much of an impact if you switch to a different statin from it. They're all cheap and they're all generic, as you know. But good question. Any additional thoughts? Tough case. We see it often. And it's just, I think that the fortunate news about this lady is she doesn't smoke and she's doing okay. She's functioning well. So you have time to work with her on lifestyle changes over the course of months or even years. Okay, let's talk about our case and apply some of the things that Aleece just spoke about. So Dr. Nora Weitz leads a 4-provider practice that has implemented changes to improve overall control of diabetes. She wishes to identify improvement associated with the practice's effort. Okay, so she's done some changes, and let's say, the changes are intended to improve delivery of certain diabetes treatments, maybe identify complications, whatever it is. Can someone think of a smart, meaningful aim, a meaningful smart aim rather, for her project? What might that be in terms of diabetes control? So the left-hand side is deliberately vague, so you can generate any sort of smart aim.
Right. This is Amber.
Go ahead, Amber.
Thinking about just identifying the amount of patients with A1Cs greater than 7, just to kind of come up with an overall idea of what that looks like in the clinic, and then kind of focus on driving that number down below 7. So, reducing the percentage of patients with A1Cs greater than 7.
Okay, so that's ambitious, but I mean, let's not worry about the numbers so much. So you want to first identify the proportion of patients with diabetes who have uncontrolled type 2 diabetes, and to reduce that proportion by a certain amount. And the timely part is over a certain period of time, let's say 6 months or so. Okay, That would constitute a smart aim. Let's move on in the couple minutes we have left. What kinds of key drivers, if you were to brainstorm key drivers, would be drivers of potential poor control in this particular practice? There's only four physicians there. What kinds of things would be the problem?
Oh, hello, this is Amber again. I would
Yep.
say things like ability to schedule, sometimes with for providers, like, you know, maybe patients can't get in timely matters because of scheduling. Um, and I'm thinking as with the four providers that maybe the work staff, like the clinical staff might be, turnover might be an issue.
Yeah, I think those are some. Any others? Well, I'm just going to offer one key driver that I've experienced personally many years ago in a small four-person practice. And that's, let's say I'm in practice with Doctors Austin and Mukherjee, and I see a patient who has a hemoglobin A1C of 9.5. And I look at the chart and I say, well, Dr. Austin saw you a couple of weeks ago and he didn't make any changes. So I'm going to wait till you see him again. And then he sees Dr. Austin and says, well, Dr. Rao didn't make any changes. He must have had something in mind. And it goes on and on. And that's one form of clinical inertia, which I think is really important, especially in a small practice where people they of course they work together as a team, but sometimes the relationships can get complicated there. Any other key drivers that you guys can think of?
Lack of the support staff for diabetes control, like dietitian, weight management, or like getting in like a multi-specialty in case if they need an endo or a pharmacist to work with them.
Yeah, a lot of these great points. Chronic conditions like type 2 diabetes are very receptive or responsive to disease management programs. And it doesn't have to be a formal program, but just having someone in the staff who can say, hey, your hemoglobin A1C is above this amount. Let's have you come in for an appointment so we can intensify your treatment or talk about lifestyle changes. That doesn't usually happen in sort of the acute or chronic episodic care models that we use in primary care quite often. Okay, so those are some key drivers. And finally, what kinds of tools, including would you use to monitor progress over time? So not key drivers or fishbone diet, but how would you know how you were doing?
Checking their A1Cs every 3 months and seeing their show rate and identifying the list of patients who has like outside resources or like just tracking the patients and getting the numbers, I guess, like A1C or like their alternate CGM monitor readings from Epic or like any.
Yeah. Yeah, I think that would probably work. So we could look, for example, at if this is only for doctors, it's probably not a huge number of patients with type 2 diabetes with uncontrolled, that's, really uncontrolled. Let's say it's 9+ or something like that. You could monitor them over the time with the My Panel tool, for example, in Epic, or sort of the slicer dicer tool in Epic as well. So that would be useful. And some of those other suggestions are relevant as well. How many had referrals to a dietitian? How many had other sorts of services provided as well? Okay. All right. I'm going to turn things back to Aleece and Andy for a second, but any final thoughts before we move on? Okay, great insights. Andy, I think we can talk about our updates.
Well, Amanda, if you want to lead this, please feel free.
Thanks. So just as a reminder, everyone, we're going to talk about Gemba walks, and we'd love for you all to talk about a Gemba walk that you have observed. So just to remind ourselves, the Gemba walk is really when you go to where the work is happening and observe the actual process. Gemba really means the real place, so where the work is happening. And it allows us to connect with staff and really make those connections. And then those connections really can lead to improvement to give us that firsthand view of what is happening in the process. So first up, we have Fisher-Titus. I think I saw David on. David, could you just talk to us about an observation of a process or a Gemba walk that you maybe have been involved in?
Yeah, good morning. Yes. So I've done this with a few of my clinical staff in the office and with the providers, and it's interesting that the age groups still kind of fall into play when we're looking at compliance with what we're trying to do with monitoring A1Cs and also monitoring their blood pressure. Having a point of care A1Cs in the office is helping us with some of our distance patients who are coming greater than a half an hour away. They're more apt to get their labs drawn. Usually it's when they leave now as opposed to before the next appointment, but that's better than what we've been getting. So that's one of the areas that we've really pushed, that we've seen that we have high incidence of people who don't want to come in a week before their appointment because their drive is too long for them and they're older. We have been getting those labs before they leave that appointment, and then we are doing the point of care A1C in the office. So with A1C, that's been helping us monitor that a little bit better. That's one of the areas that we found for improvement. And interesting enough, one of the other areas that we're really talking about right now is how we're communicating the need to the patients rather than just putting it in the patient's court to take care of. We're really trying to model our conversations with the patient to be a team effort as opposed to an individual effort on doing some of these things. So we're offering some more resources for some of the patients in the Norwalk office. We've been offering for them to give me a call because it's a direct line to me so that I can remind the patients what they need or make sure that they know what tests they have to have drawn. So we're trying a couple small things there to see if this is going to help. But the biggest one has been creating that team atmosphere with the patient so that they feel like they can accomplish this and they're not doing it on their own.
So David, as you talk about point of care testing in the office, can you kind of walk us through what that process looks like for others on the line so that if they wanted to implement that in their practice, can you talk us through what that process looks like when the patient comes in and then how you're getting that point of care testing and what that looks like?
Sure. So our clinical staff, they pre-chart certain things for the visit. And so, for example, if a patient's coming in and they're going to need an A1C, they'll put that in their HPI. The HPI in our system is the history, and that's where the staff will note what needs to be done for this visit, i.e., maybe a Cologuard, mammograms, that type of thing, A1Cs. And then, so when they come in, what we like to do is verify with the doctor that he wants that A1C. And we do that beforehand because it's a 5-minute cook time, so to speak, to get the result back. And we try to have that result when the doctor goes into the room. And so when they come in and we verify with the doctor they want that, we will do that right away during our intake. We'll, of course, wait till after the blood pressure so we don't spike that. We want to try to watch that as well. But we'll do that. And then we usually have that ready for the doctor when he goes into the room. So it's really streamlined the process of the appointment, and it really gives the patient some more assurance that when they come to the office, there's progress being made in the decisions for their health.
That's fantastic. I love the fact that you've thought about, making sure you get that blood pressure prior to getting that point of care testing so that you're not affecting that blood pressure as well. Does anyone have any questions for David about their point of care testing process in the office? Or comments from anyone? Okay, well, thank you for sharing, David.
Yeah, thank you.
Next up, we have the Healthcare Connection. I don't think they were able to join us this morning. I did see a phone number. I wasn't sure who that was. Is anyone on from Healthcare Connection? Okay. Arpitha, do you want to share a process that you've observed in your practice?
Yes, thank you, Amanda. So my project is targeting patients with increase in their ASCVD risk score over 10% who are not on statins. So the Gemba walk that we are doing is we have in our care team we have physicians, admin staff, which includes the nurse manager and the MTAs, and also the front desk, and also the not the least but patients are very important here, and the pharmacy. So basically I was thinking about how to process this well. So I was thinking maybe 5 Ws. What is the standard process that we can explain to the team? And I had a discussion with our team just to say, like, just to educate them when they call the patients, they need to understand why they're calling. So I was explaining them, and then we had a team of MTAs who brought up very well good questions about, like, why did this patient not on the statin previously, or, like, what was the issue. So bringing up the questions from the MTAs made me think, like, okay, the process has to start from here, not from the patient. And then when and where and why. So when are patients with abnormal results, when they call, has to be flagged to schedule the follow-up appointment, and where does the communication between the patient and the team or the scheduler is breaking off. If the patient asks for an appointment and the scheduler doesn't do an appointment within the time frame, are we missing the patients or turning them around even if they're interested? So trying to find the connections helps me to get the patients faster into the system.
Thank you, Arpitha. Can you, I know we worked on a process map for your project to think about really
Yes.
making sure that we had a standardized approach and a standardized process for the team to follow. I love the fact that you've engaged the team and really helped them to understand, why they were doing this work, and that way they can translate it to the patient. And then, really focusing on that team-based approach. So that's amazing. But can you talk us through
The process.
that process for scheduling the follow-up appointments with those patients with that high risk score, and
Sure.
sort of that standardized approach that the team's taking, so that if others want to learn from that, they can do that? And maybe any barriers that you've come upon, or even wins that you've had.
Okay. So the process starts like identifying the list of patients that we have with the high score, and then we get the list of the patients, and provide the list to the nurse manager, who assigns a staff member on the day. It can be different staff members, so it's hard for me to explain it to everyone. That's one of the setback. It's not one assigned person every month. So that's then they call the patients, and if when they before they call the patients, they make a note if this patient had a lipid panel within last 6 months or not, and if they don't have, they pen the order and they inform the patient before they finish the call, saying that the doctor is going to order the test, and you need to get it done before your next scheduled appointment for you to review with the provider. And then if the patient has a scheduled appointment, they have then that's good. If they say no, then they order the cholesterol labs, and they decide whether to schedule an appointment or not. They leave the option to the patient if they say no. And then once the scheduled appointment, we have the list of the patients every month to see if they actually showed up to their appointment or if they started on the statin or not. And then we follow up a month every 4 to 6 weeks to see we achieved the goal. And then if they did start the statin, they're out of the list. If they did not start the statin, but they are still interested after the lifestyle changes, we keep them on the list. Or if they have statin intolerance, we remove the patient from the list again. And then we send my chat messages close to the 3 months follow up, saying that you are due for your appointment and follow up, and your labs are in the um, ordered, and you can get it done before your next appointment. And that way the patients get reminded and motivated to do that. And if the patient scheduled an appointment, that's good on their own. If not, the MTAs call those patients who are on the scheduled follow-up. And then once we review every 3 months, we also have my chat messages and patient letters for patients who did not answer the call, and the MTAs tried calling them a couple of times, and if they don't answer, they send a reminder or my chat message. And if they don't have my chat messages, that's when it is hard to write a letter and send it. But we do have a process of doing that too. And then we have a follow-up phone call appointments in case if someone wants to talk, in case if they don't understand why this appointment is scheduled, or if the MTA cannot get a hold of the patient and just has a caregiver who speaks. So this is an optional phone call just in case it's not an appointment. And then we have the last but not the least, um, we have a list of the patients who is seeing statin clinic or like on alternate statin medications, who are or who is seeing a cardiologist outside the facility, but we don't have the n- list of the medications. So we are trying to add that in our process map, but this is so far how we are doing it, trying to call them every 3 months and scheduling an appointment and getting the labs done before the visit.
That's fantastic. Thank you for sharing, Arpitha. I love the fact that your process is so standardized and that you have several touch points throughout your process just to make sure that you don't have patients that are being missed or falling through the cracks, and that you're continually following them patients. So thank you so much for sharing.
Thank you.
Amber, are you on from Village of Healing?
Yes, good morning.
Good morning, Amber. Would you walk us through maybe just a reminder of what you're working on, and then just a Gemba walk that you've observed in your practice?
Yeah, so our current project is, our goal is to reduce the number of patients with hypertension in our clinic. And our process is that if a person comes in with high blood pressure, that we standardize how we take the blood pressure. We do an average of 3 in the office as a repeat. If that person has elevated blood pressure, even after that repeat, they are scheduled for a nurse visit for a 2-week follow-up. At that visit, the nurse is doing education. We kind of have it like phase 1, 2, and 3. So like the phase 1 is like, what is high blood pressure, focus, some diet things to kind of focus in on, giving patients like really small, smart kind of small things that they can focus on to change their diet. If that blood pressure is elevated in that nurse visit, they are asked to come back in 2 weeks, preferably with the provider. That is their choice, though, if they want to just focus on lifestyle and then come back and see the provider or the nurse in 2 weeks. Many of our patients have opted to see the provider in a follow-up 2 weeks. And our most recent experience when I did the GIMPA, one of the things that we are getting is that, patients aren't returning or have higher no-shows for the nurse visits. So we actually found out that our system doesn't do reminder texts for nurse visits. So that was something that we were able to discuss, or at least kind of work out a process on our back end, because we use a different scheduling system than our documentation. Like we have Epic, the community practice Epic. And so our billing and scheduling is through a different system. And so being able to work out a process so that our nurse visits are getting reminder text messages is something that we're working on currently because of our recent GIMPA walk. So I really do appreciate that as a process in this whole scheme that we're doing here. So thank you.
Amber, that's awesome. That's a perfect example of why these GIMBA walks are so incredibly important, because sometimes you think, a process is happening a certain way or it's standardized. But then when you really get in and observe that work, you realize it's not really happening the way that you envisioned it was happening or thought that it should be happening. So, we all assume that, yes, those messages were automatically going out. But then once you were observing the process, you realize that was a big opportunity to say, those reminder messages are so important and they're not happening. And then you were able to implement that. So that's a perfect example. So thank you for sharing. Any questions for Amber or comments? All right. We will go on to East Liverpool.
Okay, so good morning. So for East Liverpool City Hospital, the Gimbal walk that we have, so it's basically how the structure of check-in, patient encounter, and then out. So if I were to begin, so in the waiting area, so patients arrive. Sometimes they arrive too early without issue. Sometimes they arrive late, but they still get to be seen. But sometimes their appointment has to be postponed if they're severely late, because we have a lot of patients already arrive for their appointment. And then that's for the waiting area. And then the front desk, upon check-in, so they call the patient, so they require the patient to present proper identifications. And then some patients fail to bring the document required, but still gets to be seen for their appointment. But for the most part, the front desk knows what the appointment is all about and verbalizes the purpose of the appointment. Sometimes the front desk verifies with the resident physician what the appointment is all about during the day. And this may happen sometimes the resident physician fails to specify in the previous encounter what the follow-up appointment is all about. So in terms of walk path, it's well illuminated. No patient gets lost because they are guided by the medical assistant. In the examination room, it's quiet, clean, and well illuminated. So I don't think we have issues in the examination room. But in the essence of the appointment itself, most patients are cognizant about the main purpose of the appointment and gets to the point directly. Some patients bring too many issues during the appointment that are more pressing than the intended appointment is all about. So sometimes the appointment is all about rechecking A1C or cholesterol, but then they bring up something more pressing. That's why those testing may be postponed in another time. Some patients are in a hurry because someone is waiting for them at the parking lot or in the waiting room. So that blood works had to be printed on paper or postponed. And then some patients, when given a paper for labs, never gets them done. And they had to be prompted by the resident physician when they ask for medication refill, as the resident physician goes over the medication and then only to find out that there are pending labs. So we call the patients to get those labs done. And then some of the patients are just clueless about what they're taking. So we needed to go over them in terms of all their medications. And then sometimes the encounter gets too overwhelming that the appointment date is set, but the resident physician fails to encode in the EMR the purpose of the next encounter. And then this will create an issue in subsequent follow-up encounter, especially if another resident physician sees the patient in the absence of who the original resident made the orders. And then lastly, during the checkout process, because there are two walkways. Sometimes patient goes into the other walkway unnoticed, and then they fail to check out with the front desk regarding their next follow-up appointment, or regarding regarding the next follow-up appointment. So we end up the front desk ends up calling them for that matter.
Okay, so it sounds like you've been working on really standardizing the process of the resident documenting correctly and then making sure that patient gets scheduled before they leave the practice.
Yes, exactly. Because
Awesome.
again, so yeah.
Well, thank you for sharing, Jim.
Yeah,
Excited
sure.
to see all the work that you guys are doing there.
Okay.
And next up, we have Nicole from Erie County. I know we have about 3 minutes. So Nicole, if you want to share with us what you guys are doing there.
Hi, good morning, everyone. I'll be quick. I promise I won't go past the 3 minutes. One of the QI project that we're really working on is a little bit more innovative, and it's a little bit different and a new learning opportunity for us. So our focus has been on patients with A1Cs greater than 9 and those that have been untested. We recently, within the past 6 months, partnered with a local food pantry, and for the beginning of the project, we were looking at patients who were flagged with food insecurity with utilization of their Prepare assessment tool. And we decided that why don't we expand this to the Cardio project, and those that have an A1C that's greater than 9 or untested or have a diagnosis of diabetes, we'll provide them with a food kit, which has some healthy food options in there to see if that can directly affect their A1C numbers. So that was a learning process for our staff. Reason being, our food pantry is located in an area that's a little bit further away from patient rooms. So one of the things that we decided to do is work with our community health workers to put food kits in cabinets in each of the patient rooms. So they were easily accessible. It wasn't I got to stop what I'm doing mid assessment and go get a food kit and bring it up. We've noticed that if they're not easily accessible in the rooms, then staff can forget. So that was one of the measures that we put into play to make sure that we're addressing that. One of the other things that we're doing is it's how we present the information. There's patients that have food insecurity, that have diabetes, that aren't very forthcoming with that information, just due to potential, they think that, it's a stigma or they're embarrassed about it. So we've phrased it in a way of, hey, we've partnered with a local organization to provide our patients with food kits. You're going to go home with one today. And then we give them the choice too. These are the listed items that we have available. What would you like out of these items to go in your food kit? So it's not really asking them if they want one. It's just saying, hey, we have this and you're going home with it. What would you like in your food kit? So they've been receiving that a lot better.
Thank you, Nicole. That is so amazing. You guys are doing awesome, innovative work there. Two things I heard from your GIMBA observation is that you noticed that there was a stigma attached to the food kits. And so you were able to just say, hey, we're going to provide this to all diabetic patients in hopes that it would help. And then one thing I also wanted to mention that you were providing education for diabetic patients during those visits as well. When you give the food kits, you really include that education. And then another thing that I heard you mention is the location of the food kits. And it can be, when you do these gimbal walks, it could be literally something as simple as the location of where something is that you're observing that staff have to go out of their way to obtain it. And maybe not using it. And so you were able to move those into the rooms and now they're easily accessible. So thank you so much for sharing that. And Andy?
Perfect. Thank you so much. Just as a heads up, we will have our next cardio webinar in December, and we invite you all to join us. There is a free credit of CME for attending, and you can register at cardio.org. And then the same reminders as usual. A post-clinic survey was emailed to you about 10 minutes ago. Please complete that by next Friday, October 10th. And then as a reminder from Claire, your next set of de-identified data is due the 7th for September. And let us know if you have any questions. Otherwise, we'll see you November 6th.
Thanks, everyone. Have a great day.
Thank you, everyone.
Goodbye.
Bye-bye.
Thank you.
Thank you.